You know that feeling. It's 3 a.m., the house is dead silent, and you're staring at the ceiling, and you cannot breathe through your nose.
Oh, it's the worst.
It is the universal human annoyance. You think, okay, it's a cold, or maybe the pollen's high.
Or you just slept with your face mashed into the pillow wrong.
Exactly. So you grab a tissue, you blow, nothing. It's like hitting a brick wall.
We've all been there. But for an ENT and ear, nose, and throat specialist, that stubborn, stuffy nose isn't just an annoyance. It's the opening chapter of a very complex detective story.
And that is exactly what we're digging into today. We're looking at a stack of lectures and clinical notes on the differential diagnosis of a nasal mass.
Which sounds incredibly dry, I know.
It does. But when you get into it, it's this fascinating mental roadmap that doctors use to figure out, what exactly is that lump in your nose?
And it's a roadmap where the destination really, really matters. Because while most of us think blocked nose, the reality in these papers ranges from an annoying allergy to brain tissue leaking into your face.
Or a tumor caused by your job. Yeah, the sources we have today are pretty intense. We're going to cover everything from simple polyps that look like peeled grapes to rare fungal infections from swimming in ponds.
Right.
So the mission for this deep dive is pretty simple. We want to turn you, the listener, into a bit of an armchair diagnostician.
By the end of this, you should be able to look at a list of symptoms, how the mass looks, who the patient is, where it's coming from, and have a pretty good idea if you're dealing with a simple allergy or a medical emergency.
Okay, so let's unpack this, because it turns out not all blocked noses are created equal. And the first big distinction our sources make is in the world of polyps. I always thought a polyp was just
A simple little lump, yeah. But there's a huge rivalry, clinically speaking.
a rivalry.
A massive one. We're usually looking at two main characters.
Yeah.
The antrachoanal polyp and the ethmoidal polyp. They sound similar, but they're completely different beasts.
And the sources have these great mnemonics to tell them apart. I love a good mnemonic.
Me too. It's the only way to remember this stuff sometimes.
The first one is for the antrachoanal polyp, or ACP. The mnemonic is a single max choosy child.
Right. It sounds a bit like a bizarre nursery rhyme, but it breaks down the pathology perfectly.
Okay, let's break it down. Single. That's about the number of polyps.
Exactly. Antrachoanal polyps are almost always solitary, unilateral, meaning it's just on one side. You look up there with a scope, you see one distinct mass.
Not on both sides.
Very rarely.
Then max, that's where it comes from.
Yep. The maxillary sinus antrum, that's the big sinus space in your cheek right below your eye. The polyp starts growing in there, inside the antrum, before it decides to go for a walk.
And then it gets choosy, which I'm guessing doesn't mean it has extensive taste.
No, it describes the growth pattern. It grows posteriorly, so backwards towards the choana.
Choana, that's the back of the nasal passage.
It's the back door, basically. The opening that leads from your nose down into your throat, the nasopharynx. So it's choosy because it heads straight for that back exit.
It's trying to escape.
You got it. And because of that path, it gets this very specific shape. The sources call it trilobed.
Trilobed.
Yeah, think of it as having three parts. A natural part where it starts, a nasal part as it squeezes to the opening, and then I call anal part as it hangs out the back. It can look like a dumbbell because it gets squeezed in the middle,
And finally, child.
because it's much more common in children and young adults. So you have a teenager with a one-sided blockage, you see a smooth, glistening mass growing backward. Your brain should just be flashing. Antrachoanal.
You mentioned smooth and glistening. Is that the typical look?
It is. They're often described as pedunculated.
Which is a fancy way of saying it's on a stalk.
Exactly, like a cherry. It looks smooth, shiny, almost like a polished stone, but soft.
Okay, so what causes them? Is this just bad allergies? Because I hear polyp, I think hay fever.
And surprisingly, no. This is the key difference. The source material is very clear. These are usually caused by infection, not allergy.
So if you looked at the cells,
You wouldn't see many eosinophils.
those are the white blood cells that scream allergy.
That's the one. No eosinophils, no allergy, which explains the treatment. You can't just spray some Flonase on it and hope it shrinks.
Right, because it's not allergic?
Correct, it doesn't respond to steroids. You have to cut it out. Surgical excision, usually functional endoscopic sinus surgery, or FESS, is the way to go.
And the good news?
If you get it all out, including the root and the cheek sinus, it rarely comes back.
Okay, so that's the single max choosy child. One-sided, from an infection, needs surgery. Now let's meet the rival, the ethmoidal polyp. The mnemonic here is both ethical adults.
Which sounds like a very dull political party.
It really does. So both must mean it's bilateral.
Yes, almost always on both sides. You look up there, you're going to see masses clogging both nostrils.
And ethical stands for.
The ethmoid sinus. Unlike the other one that started in the cheek, these come from the ethmoidal air cells, those little honeycomb-like sinuses right between your eyes.
At the bridge of the nose.
Mm-hmm.
And adults, well, that's self-explanatory.
Yep, much more common in adults. And the look is totally different. The ACP was that one smooth mass. Ethmoidal polyps are described as multiple grape-like masses.
I can picture that perfectly. Just a bunch of pale grapes stuffing up the nose, and I'm guessing the cause here is different too.
It is. The histology here is full of eosinophils. This screams allergy. These patients usually have a history of asthma, hay fever, that kind of thing.
And because it's allergic, the treatment strategy just flips, doesn't it?
Completely. You start with meds. Steroids can actually shrink these a lot. Surgery is plan B, really, if they're just too big or the drugs stop working.
But the downside I saw in the notes is recurrence.
Unfortunately, yes. You can't cure the underlying allergy, so these have a high chance of growing back. It's a chronic condition.
Okay, so I think I've got the polyp war down. Now we have to shift gears. We have to talk about the cases where a nasal mass isn't a polyp at all. In fact, sometimes it's not even supposed to be in the nose.
And this is where it gets very high stakes.
This is the part of the deep dive that actually gave me chills. We're talking about congenital masses, stuff you're born with, and the risk of mistaking brain tissue for a nasal lump.
It's a terrifying scenario, usually in infants. If you think it's a simple polyp and you try to biopsy it or pull it out, and that mass is connected to the brain, it can be catastrophic.
The sources break this down into two main scary categories, gliomas and encephalocele. A glioma, that sounds like a brain tumor.
Well, in this context, a nasal glioma is a benign mass of gliols tissue. So brain tissue that's ectopic, it's out of place. But crucially, the connection to the brain has been cut off. The skull bone is closed up behind it.
Okay, so it's a piece of brain tissue stranded in the nose, isolated.
Right. It's firm, non-compressible. It doesn't pulse. It's just sitting there.
Contrast that with an encephalocele.
The encephalocele is a herniation. There's an actual hole in the skull base, and the brain tissue, or its covering, is physically spilling down into the nose. It's still connected.
That's horrifying, and the description reflects that, right? The source says it's soft, bluish, and can be pulsatile.
It can, yeah. It can pulse with the heartbeat and the pressure of the cerebrospinal fluid. It's also often translucent light shines through it, and it's compressible. You can push the fluid back up.
And there's a specific test for this, right? The Furstenberg sign.
The critical clinical test is very simple. You just watch the mass while the baby is crying or straining.
Okay, so the baby cries, pressure builds up in the head. What happens in the nose?
If the mass expands, gets bigger when the baby cries, that's a positive Furstenberg sign. That points to an encephalocele.
Because the crying pushes more fluid down through that hole into the mass.
Exactly. It confirms that active connection. If the mass doesn't change size, a negative sign, it's likely a glioma. The connection is closed.
Wow. So crying baby, bigger lump. Do not touch that lump.
Precisely. Step away from the baby and order an MRI.
Okay, moving on from the scary baby stuff. Let's talk about tumors, but the benign ones first. There's one here called the inverted papilloma.
Yes, this one is deceptive.
The name sounds odd, but the description caught my eye. Fleshy, pink, or gray on the sidewall. But there's a key clue about how it feels when a doctor pokes it.
It's insensitive to touch. It doesn't hurt. And this is a really important differentiator because malignant tumors are often painful. You poke an inverted papilloma, the patient barely notices.
So why do we worry about it if it's benign?
2 reasons. 1, it's associated with HPV. And 2, it has a potential to turn malignant into squamous cell carcinoma, so it's on a watch list. You have to remove it completely.
Got it. Now, sticking with benign tumors, there's one that seems to target a very specific group. The juvenile nasal angiofibroma, or JNA.
Oh, this is a classic board exam diagnosis. If a 14-year-old boy walks in with a history of massive repetitive nosebleeds, JNA is the first thing in your mind.
It's almost exclusively adolescent males.
Almost exclusively, it's hormonally driven, linked to testosterone, puberty.
The source says it's pinkish and smooth, but the key is that it's extremely vascular. You can actually see the vessels.
It's basically a ball of blood vessels and fibrous tissue. And the warning here is huge. Do not biopsy this in the clinic.
Because it'll bleed a lot.
Torrentially.
Yeah.
I mean, a dangerous amount of blood. You diagnose this with a CT scan, not by cutting a piece off. You will get in a lot of trouble very quickly.
All right, noted. Don't poke the bleeding teenage nose tumor. What about hemangiomas? Are they similar?
Similar in that they're made of blood vessels, but the presentation's different. There's the capillary hemangioma, often called the bleeding polypus of the septum. It's a dark red mass right on the septum, usually near the front.
And the other one?
The cavernous hemangioma. That one's usually on the turbinates, the sidewalls, and it's more purple and spongy. They bleed, but they aren't the surgical nightmare JNA is.
All right, let's shift to the malignant tumors, the ones we really don't want to find. The sources give a sort of general warning checklist. How do you spot a bad actor?
Well, if you look inside the nose, a malignancy often looks angular. It's irregular, not a smooth grape. It has verted margins, so the edges roll outward, and it's friable.
Friable. That just means it crumbles or bleeds really easily.
Very easily. You just graze it with a tool and it starts to bleed. And unlike that benign papilloma,
It hurts.
it's often sensitive.
Yeah.
Pain is red flag. A painless lump is often benign. A painful, bleeding, irregular lump is worrying.
The most common is squamous cell carcinoma. But there's another one here with a fascinating link to a specific job, adenocarcinoma.
Yes, this is the classic woodworker's tumor.
Woodworkers, really?
Specifically hardwood. There's a very strong, well-documented link between long-term exposure to hardwood dust and adenocarcinoma of the ethmoid sinus.
That's wild. So the sawdust is causing it.
It creates chronic inflammation, the dust gets trapped, and over decades, 30, 40 years, the cells could change. So if you have an older patient who is a carpenter for 40 years,
Yeah.
you have to suspect this.
That's exactly the kind of detective work I love. History matters. Okay, what about melanoma? I think of that as skin cancer.
It can happen inside the nose, too.
Yeah.
And it's tricky because while it can be black, like a mole, it can also be a melanotic, which is pink or flesh-colored.
So a pink lump could be melanoma.
It could be. You can't just judge by color.
And then there's one with a very long name, esthesia neuroblastoma.
It's a mouthful. Olfactory neuroblastoma. It comes from the olfactory nerves, the ones you smell with, right at the top of the nasal cavity.
It has a weird age distribution.
Bimodal, yeah. It peaks in people in their 20s and then again in their 50s.
Okay, we have covered a lot. Now I want to get into my favorite category from the sources. I'm calling this section the weird, the gross, and the fungal.
It's a very apt title. The nose is a warm, moist, dark place. Things like to grow there.
Let's start with rhinosporiosis. This sounds like something from a horror movie.
It has a very distinctive look. It's described as a strawberry-like polypoidal mass.
A strawberry. In the nose.
Yes, red, bumpy, bleeds easily. But if you look closely, the surface is studded with tiny white dots. Those are the sporangia, the spore sacs.
Ew. And the history clue for this one is so specific.
Pond water. It's caused by an organism that lives in stagnant water. It's common in places where people bathe in ponds, especially ponds shared with cattle.
So, strawberry mass plus pond swimming equals rhinosporiosis. What about mucormycosis? I've heard this before.
Yes, and this is a medical emergency. It's an aggressive fungal infection. It typically presents as a black necrotic mass.
Necrotic meaning dead tissue.
Right. The fungus invades blood vessels, cuts off the blood supply, and the tissue just dies and turns black. It erodes bone. You might see a black spot on the roof of the mouth.
And you have to act fast.
Incredibly fast. Surgery and heavy-duty antifungals. It loves patients with uncontrolled diabetes or suppressed immune systems.
Then there's allergic fungal sinusitis. This one has the most vivid description of mucus in the entire source text.
You're thinking of the peanut butter?
I am. I may never eat a PB&J again.
It's a classic description. The patient produces allergic mucin. It's thick, sticky, yellow, green, or brown, and the consistency is almost exactly like peanut butter.
If you suction out peanut butter, think fungus.
You got it.
Okay, before we wrap, we have to mention the decoys. The things that look like tumors but aren't.
The imposters.
Imposter.
First up, the rhinolith.
Literally nose stone. It's a grayish-brown, rock-hard mass. It usually forms around a foreign body that was stuck up there years ago. A bead, a seed, and salts deposit around it.
A pearl, but terrible.
Very ugly nasal pearl. And it often smells terrible.
Then there's the hypertrophied turbinate. This is just swollen normal tissue, right?
Correct. The turbinates are the radiators of the nose. In allergies, they swell up and can look like a big red mass.
How do you tell the difference?
The decongestant test. You spray some decongestant in the nose. If the mass shrinks, it's just a turbinate. Tumors don't shrink.
That is a neat trick. And finally, the most humbling diagnosis of all, the blob of mucus.
It happens to the best of us. You see a mass, you panic, you stick the suction in there.
And poof, it's gone. You're cured.
Always try to suction it first. Sometimes a booger is just a booger.
So what does this all mean? We've gone from single max choosy polyps to pulsing brain hernias and woodworker's cancer. It connects back to the start. The diagnosis isn't just about spotting a lump, it's about the story. Is the patient a teenager with nosebleeds? An elderly carpenter, a baby whose nose swells when she cries.
The nasal mass is just the final piece of a much bigger puzzle.
Precisely. And knowing the difference, knowing you don't biopsy the pulsing mass or the bleeding adolescent mass, that's what makes a good clinician. It's about having that mental roadmap.
And for the rest of us, it's a reminder that a stuffy nose can be a lot more than just a need for a tissue.
It can be a window into the body's history.
I'm going to leave you with one thought to mull over. We talked about that blob of mucus being a decoy. It's funny, but it makes you wonder, how many times in life do we catastrophize a problem, thinking it's this permanent, scary obstruction, when really it just needs a little bit of section? Sometimes the scariest looking things have the simplest explanations.
That's a profound way to look at nasal secretions.
I try my best. Thanks for joining us on this deep dive.
Thank you.